My name is Katja Weisel. I'm from the University Hospital of Tübingen in Germany, and I'm here at the ASCO 2017, and I presented the efficacy of the monoclonal anti-CD38 antibody Daratumumab in combination with standard of care regimens in patients with relapsed and refractory multiple myeloma based on cytogenetic risk analysis. These were updated data from the two large phase 3 trials which were conducted in parallel in patients with relapsed and refractory multiple myeloma in a multi-center, multinational setting, and those trials called Castor and Pollux. And in the Pollux trial, the Daratumumab was added to the lenalidomide dexamethasone backbone regimen and randomized against lenalidomide and dexamethasone alone. And in the Castor trial, patients received Daratumumab in combination with bortezomib dexamethasone, and this was compared to bortezomib dexamethasone alone. And the primary efficacy analysis of those trials was published last year, and now we showed first of all the one-year update regarding progression-free survival. So with now an extended median follow-up in the Pollux trial of 25.4 months. The median progression-free survival for Daratumumab in combination with lenalidomide and dexamethasone was not reached, though, compared to 17.5 months in the standard arm, and this was highly significant with a hazard ratio of 0.41. And in the Castor trial, the extended follow-up now reached over 19.4 months. And there, the median PFS for Daratumumab in combination with bortezomib and dexamethasone was now reached with 16.7 months compared to 7.1 months in the standard bortezomib dexamethasone arm. And in the Castor trial, it was shown that patients with only one prior treatment line benefited most regarding the addition of Daratumumab. And then we looked on the cytogenetic risk status. In both trials, cytogenetic risk status was assessed by next-generation sequencing. These were the first prospective trials doing that with this methodology. And we showed that there was a very high concordance rate between next-generation sequencing and local FISH analysis, which also was done by a subset of patients with a concordance rate of both methods from 88 to 100%. And for cytogenetic high-risk patients, it was also shown that the addition of Daratumumab resulted in a better outcome regarding PFS. In the Pollux trial, there was median PFS for high-risk patients with Daratumumab in combination with lenalidomide and dexamethasone of 22.6 versus 10.2 months, with a strong trend towards Daratumumab. And for standard risk patients, again, the median PFS in the Daratumumab arm was not reached. And in the Castor trial, also the high-risk patients showed significant benefit in median progression-free survival when Daratumumab was added to the standard of care. However, in both trials, the addition of the monoclonal antibody did not overcome the cytogenetic risk status. Regarding overall response rate, it was shown in both trials that the addition of Daratumumab led to a higher overall response rate, and it also deepened responses with a higher rate of complete remission and stringent complete remission. Moreover, there was an analysis for minimal residual disease, and it was shown that high-risk patients achieved only a minimal residual disease state in the Daratumumab containing treatment arms in both trials. And for standard risk patients in both trials, there was a significant higher MRD negative rate when Daratumumab was added to standard of care. Interestingly, despite a very low absolute number of patients, high-risk myeloma patients achieving this MRD negative state with Daratumumab containing regimen remained progression-free during the follow-up period. So that in conclusion, we can say that the addition of Daratumumab to standard of care regimens consistently prolongs progression-free survival regardless of cytogenetic risk. It deepens responses, and especially despite a low absolute number, it's very promising that also high-risk patients received MRD negativity and remained progression-free during follow-up.